Here we present a complex case of a patient with a large tentorial arteriovenous fistula that was embolized transarterially in combination with a transvenous approach. The patient is a 61-year-old female who had past medical history of hypertension and coronary artery disease. She presented with acute and chronic onset of right pulsatile tinnitus, vertigo, and decreased hearing, especially on the right side. Her neurological examination was normal and non-focal. She was currently taking aspirin and clopidogrel. Her CT scan was normal, however, the MRI demonstrated a possible vascular lesion along the free edge of the tentorium on the right side that had a prominent venous drainage in relation with the brainstem, including the vein of Rosenthal. Based on this imaging, we suspect arteriovenous fistula or arteriovenous malformation, and an angiogram was the next step for further evaluation. This angiogram demonstrates the complexity of the fistula, multiple feeders coming from occipital, middle meningeal artery. In this lateral view, you can observe better the multiple branches. Again, the occipital artery and multiple branches of the middle cerebral artery, and a very large tortuous draining vein into the vein of Rosenthal. So first, we try a transarterial approach. The procedure was performed under conscious sedation through a right femoral artery approach. A large guide catheter is in the external carotid artery. An intermediate catheter was navigated into the maxillary artery, and the microwire microcatheter, as you can observe, are navigated into the branches of the middle cerebral artery. Here you can observe the intermediate catheter advance for more support, so the microwire and microcatheter could navigate easily. You can see how the middle meningeal artery is always the safest and the easiest route to approach this tentorial or any dural AV fistula. We're following the microwire and microcatheter into that distal branch of the middle meningeal artery. Now we're turning the microwire down to really approximate the microcatheter as close as possible to the fistula. And this is as far as the microcatheter will go. We remove the microwire and purge the microcatheter with DMSO, and using Onyx 18 we start embolizing slowly this large tentorial fistula. Here the Onyx is going first into the branches of the occipital artery. Once some of those branches are embolized, then the Onyx keeps on going into the actual fistula's connection and into the venous pouch, and then you will see the Onyx also going into other branches of more proximally of the middle meningeal artery. More Onyx is injected to really fill in the venous pouch and the normal connection. On a AP view, you can observe how the cast of Onyx into the fistula is being filled, and some other dural branches. We perform another angiogram through the intermediate catheter and observe that the fistula is still present. There is still a small portion of the proximal segment of the fistula that is still filled from this hyperplastic and abnormally enlarged branch of the middle meningeal artery. We try several times to get access into that artery. You can observe the wire. Because of the tortuosity here, the wire and the microcatheter don't really want to take that turn. So we stopped there, and we then went ahead and obtained vein access. We have a large guide catheter into the venous system with the wire passing through all the valves of the vein, and we advance the large catheter into the internal jugular vein of the contralateral side. You can see the two large catheters, one in the arterial side and one in the vein side at the left. We then perform an arterial angiogram to delineate the venous structures. You can observe that the large guide catheter is at the bottom of the sigmoid sinus. Using a roadmap from the arterial angiogram, we use also an intermediate catheter and a 0035 glide wire to have access into the sigmoid sinus, transverse sinus, and then turning the wire to get access into the distal portion of the superior sagittal sinus, and then eventually turn around into the straight sinus. Here we are advancing the large guide catheter for more support to the intermediate catheter. The intermediate catheter has again the glide wire, and eventually we're able to pass the intermediate catheter at the origin of the straight sinus. We then rotate the view. You will see how the fluoroscopy is rotated in a certain way that now we are able to open the angle from the straight sinus into the deep venous structures, in this case the vein of Rosenthal. Once we open the angle for better visualization, we perform another arterial angiogram to delineate the venous structures. You observe how nicely now we observe the takeoff of the multiple veins that we need to go through in order to get the foot of the vein that comes off the remaining nidus of the fistula. Here we're navigating with a microwire, a 0014 microwire, followed by a 0017 inch microcatheter. We continue advancing the microcatheter over the microwire carefully through these delicate veins. And this trick here is that we really need to get into the very proximal junction of the fistula and the vein. And based on this venogram, it looks like we have obtained access exactly where we need it to be. We then remove the microwire, purge the microcatheter with DMSO, followed by Onyx. In this case, we're using Onyx 18 again. And slowly filling the fistula. We are allowing some reflux into the microcatheter to also obtain some occlusion of the vein. Another angiogram still demonstrating that there is still fistula. We inject a little bit more Onyx and complete the obliteration. Once we have sufficient venous reflux, we then slowly pull the microcatheter. As you can observe, you will see the Onyx cast slightly moving at the, simultaneously as we pull the microcatheter. The microcatheter may take some time to release from the Onyx cast. In this case, it came out nicely. Another internal carotid angiography demonstrates complete obliteration of the fistula. As you can observe here, there is very slow flow into that abnormally enlarged vein that eventually will thrombose. The patient did very well and was discharged 24 hours after the procedure. She returned 6 months later with follow-up MRI demonstrating no evidence of fistula recurrence. Thank you.